Once prostate cancer has spread beyond the prostate, it's not curable. It's treatable, but not curable. So it is important that we diagnose it early when it's localised to the prostate and is therefore curable. Age is an important risk factor and certainly much more commonly diagnosed when you're over 50. Certainly there's a lot of men are at risk, particularly if they have a family history of being diagnosed, and we do diagnose men in their 50s and 60s and occasionally younger. It's estimated that in Australia at the moment there are about 122,000 men living with prostate cancer, and so the earlier we can diagnose it, less side effects, minimise treatment related effects, minimise disease related effects. There are many tumours that are not so aggressive and don't need necessarily treating. We put on surveillance, for example, but we do need the biopsy material to get that information. Traditionally, we've performed biopsies by passing a needle through the rectum into the prostate. We use a transrectal ultrasound probe to image the prostate. There's a risk of infectious complications because we're going through the rectum, and we use antibiotic coverage or prophylaxis to try and protect against that, but no matter what precautions are taken, there's still a risk of infection because it's going through a dirty area, contaminated field. We try and minimise the use of antibiotics to avoid antibiotic-related illnesses and also multi-resistance. The biggest change really has been the change from transrectal biopsies to transperineal biopsies. Now, the main driver of moving to transperineal biopsies was the infection risk. It's not zero with transperineal, but it's exceptionally low. So you can anaesthetise that area, so then you have the potential to go to local anaesthetic. The advantage of a local anaesthetic for the patient is that it avoids a general anaesthetic. It's still done as a day case, getting to the anterior part of the gland, particularly if it's a big gland, and the anterior tumours have been traditionally missed with previous biopsy techniques or diagnosed late, leading to poorer prognosis. So I'm a lot more confident now if an MRI shows an anterior tumour, or any sort of tumour, but particularly anterior tumours, that I can get to it. And certainly the literature supports that idea as well, that in combination with MR you tend to pick up more significant cancers and you don't diagnose so many insignificant cancers.